Hello everyone. In this module, Harvey and I are going to deal with more complex macular holes. By complex macular holes, we mean post-traumatic macular holes, or they are associated with retinal detachment. They could be large macular holes more than 1400 microns, or a previously failed macular hole surgery, or associated with pathological myopias or a long eyeball, or a combination of any of these above. Now, this is a case of a traumatic macular hole. You can see a lot of pigmentary disturbance which is caused by the Berlin's edema due to the trauma, and eventually a hole has formed. The previous steps are all the same. You do a PVD creation followed by an ILM peel. Once this is done, I use the massager to approximate the edges. A lot of traumatic macular holes tend to be large, and this approximation with the massager helps a lot in getting the hole smaller or almost closed in most situations. So we do this circumferentially to relieve the traction. And this is an atraumatic maneuver because the edges of the massager are smooth. Once this is done, we do air fluid exchange and then drain from over the hole, and you can see the hole becoming pinpoint and almost closing. Now this is a case of a retinal detachment with a horseshoe tear associated with a macular hole. So here we use a stain, but because the retina is mobile, we put perfluorocarbon, and after that remove the ILM. Once the ILM is removed, I use the massager to approximate the edges of the hole so as to release the traction. So this is being done under perfluorocarbon. So once this maneuver is done, after that air fluid exchange is done and endodrainage is carried out through the horseshoe tear so that the retina flattens. And after that we drain from over the disc and macula so as to approximate the hole. At the end of the surgery, we do laser to the horseshoe tear and the hole shuts. I wanted to show you one of the common complications of macular hole surgery, which is due to the PVD creation, sometimes peripheral retinal breaks form. And they are very common in the inferior periphery. As you can see here, after a PVD creation, there are a few flaps and a mild bleeder which is seen, which tells you that that surface is disturbed and there could be a small hole there. So the main aim is to remove the vitreous from there. After that, you carry on with the macular hole surgery steps one by one, and once you finish, at the end of surgery, we do laser barrage to that whole area so that the patient does not come back with a retinal detachment. At this stage, I will let Harvey take over and show you some more examples of complex macular holes and how he uses adjuncts to deal with them. Thank you very much.
Thank you, Manish, for that wonderful presentation of cases and those very innovative techniques that you illustrated. So for this next section, we're going to talk about some more complex cases of macular hole and our different surgical approaches. So the prognosis for successful repair of idiopathic or conventional macular holes is very good. However, there are a variety of complex macular holes with more guarded outcomes. Here we will describe some approaches for these complex macular holes. So examples of complex macular holes include very large hole diameters, larger than 1400 micrometers. Macular holes are also more difficult to repair when they are associated with retinal detachment, very long eyeballs, previously failed macular hole surgery, and ocular trauma. In these cases, the level of surgical difficulty increases. For example, if you had a macular hole on a detached retina, you may actually need to stabilize the detached retina to aid with your ILM peeling. For very long eyeballs, there's often a need to stain repeatedly for you to identify the ILM very well. And you may need long instruments to reach back to peel the ILM. The use of ILM flaps as an adjunctive maneuver for macular hole surgery was nicely described earlier by Manish. But what if you had already done previous surgery and the ILM had already been peeled? What steps can we now take to promote macular hole closure? So amniotic membrane patches have been used by the group of Stanislaw Rizzo to aid in the closure of post-traumatic and very large macular holes. Their series utilized cryopreserved amniotic membranes, which are not widely available around the world. In our practice, we use commercially available dehydrated amniotic membranes which do not require special storage facilities and are easily transportable. For our surgeries, we usually use retinal forceps that are 1 gauge smaller than that of the trocars that we use for vitrectomy. This allows the amniotic membrane to be brought in easily through the trocars. A soft tip cannula is also helpful for maneuvering the amniotic membrane once inside the eye and when it's on the ocular surface. Tamponade agents can also help keep the amniotic membrane in place until the hole closes. So after staining the amniotic membrane, we use a one-step smaller gauge retinal forceps to grasp the membrane and insert it easily through the trocar into the vitreous cavity. The amniotic membrane is then gently laid down on the fluid surface after completing near total fluid air exchange. A soft tip cannula can then be used to gently position the membrane over the macular hole. The remaining fluid can then be aspirated over the disc. And when you do this, this causes the amniotic membrane to gently settle down over the macular hole, covering it. We call this macular hole patching. The trypan or brilliant blue stain provides excellent visibility even through the air-filled eye. Appropriate tamponade agents can then be introduced with post-operative positioning according to the surgeon preferences. So whether you're using gas or silicone oil tamponade, the surface tension caused by these agents keeps the amniotic membrane in place, as seen in this post-operative photo. Optical coherence tomography will additionally demonstrate cellular proliferation, helping to fill the hole. And you can also see sometimes the amniotic membrane create this pigtail sign representing curling of the amniotic membrane edges. Macular holes are infrequently associated with retinal detachment, and usually this happens in association with pathologic myopia. Visualization is usually a challenge in these cases, and in my practice, I like to reflux brilliant blue or trypan blue dye directly on the macula using the 25 gauge bevel tip cutter. By doing this, we can get a very nice staining or coloration of the retina. I usually wait about 2 minutes to further promote good staining. So you can use either a pinch peel technique using retinal forceps, or you can use the finesse loop to scrape the surface of the ILM to create an edge. After which you can use end grasping forceps to peel off the inflexible ILM in an effort to loosen the retina and facilitate reattachment as well as macular hole closure. When the retina is very mobile, it may be necessary to stabilize the retina with liquid perfluorocarbon placed over the macular hole and posterior pole. This is a case of a failed macular hole surgery with a partly detached retina. In the image on the left, you can see that there's a submacular fluid and a frankly open hole. So dehydrated amniotic membrane patch was then applied, and the patient was placed on face-down positioning with SF6 tamponade. A week after surgery, a repeat of OCT demonstrates the closed hole with a patch on the RPE and cellular proliferation at the hole location. In this case, we had placed two amniotic membranes, and one of them was actually a little off-center, and it created this figure of 8 sign. And in the last picture on the right, taken a month later, you can see now very nice closure of this macular hole with recovery of visual acuity to 2200 and complete resolution of subretinal fluid. So other adjunctive maneuvers include the use of autologous blood or autologous serum with or without the dehydrated amniotic membrane patching. And there are also some very brave surgeons using autologous retinal free flaps. So they harvest a piece of retina in the periphery and transplant it over the macular hole to close it. So in this case of recurrent retinal detachment in a high myope with macular hole, we did our usual dehydrated amniotic membrane technique. We applied this on top of the hole, completed the fluid air exchange, and then we applied a drop of the patient's autologous blood to provide additional adhesion as well as add possible growth factors. So you can see here in the photograph after the surgery, there was amniotic membrane with some tinge of heme. You can also see very nice closure of the amniotic membrane 2 weeks after. And 1 month after, you can see a plug of heme still over the hole. And 6 months later, you can see now that the hole has completely closed. And in this case, the patient was able to obtain a good visual outcome. So take-home messages. Basically, macular holes are a common cause of visual impairment. Uh, but conventional holes usually will lead to very good visual outcomes. Complex macular holes lead to poor outcomes. They have guarded prognosis, but there's an ever increasing number of adjunctive maneuvers and surgical steps that are giving us better and better outcomes. So I'm sure in the future there will be even more ways to improve our outcomes with macular hole surgery. Thank you very much to all of you for watching this macular hole module. I'd like to thank my colleague, Dr. Manish Tagpal from India, for presenting his wonderful cases and giving us his insights into the management of this complex condition. And thanks to Alcon for supporting this educational activity.